Asthma is a chronic inflammatory disease of the airways. Inflammation, bronchoconstriction, and mucus cause the reversible obstruction of the airways. Asthma can occur at any age, but late-onset asthma is attributed to the hygiene hypothesis. The hygiene hypothesis states that people who have reduced exposure to germs and infections may develop a hyperreactive immune system. Signs and symptoms of asthma include wheezing, coughing, chest tightness, and shortness of breath. These symptoms vary over time and are worse at night or early morning. Asthma becomes worse in the presence of certain triggers such as dust mites, pet hair, smoke, mold, pollution, and even upper respiratory tract infection. Before we start with diagnosing asthma, we need to define the forced expiratory volume and the forced vital capacity. But before we do that, make sure to hit that subscribe button. FEV1 measures how much air a person can exhale within the first second of a forced breath. Forced vital capacity, FVC, is the total amount of air you can exhale after a complete inhalation. Diagnosis of asthma requires the FEV1 over FVC ratio. In asthma, the FEV1 over the FVC ratio is lower than the normal, less than 70%. The goal of treatment of asthma is to reduce inflammation, which controls the symptoms, reduces the risk of exacerbations, and reduces the decline in lung function. Now we are going to start with a stepwise approach for the control of asthma in adults. Starting with step 1. The symptoms for step 1 occur less than twice a month. It's not frequent, so the treatment is as needed low-dose inhaled corticosteroids with formoterol, which is available under the brand name Symbicort. In step 2, the symptoms happen twice a month, or more but not daily. We can treat step 2 like step 1 using as needed low-dose inhaled corticosteroids with formoterol like Symbicort, or we can use a daily low-dose inhaled corticosteroid as a controller plus a short-acting beta-2 agonist as a reliever. Example, beclomethasone dipropionate plus albuterol. Or we can use leukotriene receptor antagonist as a controller plus short-acting beta-2 agonist as a reliever. Leukotriene receptor antagonists are used when the patient cannot tolerate taking inhaled corticosteroids, or when the patient is suffering from allergic asthma and allergic rhinitis. An example of a leukotriene receptor antagonist is montelukast. Montelukast is used for adults and children, and it is available in many doses. Step 3 symptoms can happen most of the day, or the patient is waking up in the middle of the night because of the asthma symptoms. Once a week or more, we can use low-dose inhaled corticosteroids with LABA, such as budesonide with formoterol, or medium-dose inhaled corticosteroids such as beclomethasone. We start step 4 by checking for the patient adherence. Does our patient know how to properly use the inhaler? Symptoms of step 4 mean that the patient is suffering most of the day, waking up in the middle of the night because of the symptoms more than once a week, and even shows low lung function. The treatment starts with medium-dose inhaled corticosteroids or medium-dose inhaled corticosteroids with long-acting beta-2 agonists, with short-acting beta-2 agonists when needed. We can even use add-on treatments such as leukotriene receptor antagonists. Step 5 is severe allergic asthma. The treatment is high-dose inhaled corticosteroid with long-acting beta-2 agonists, or high-dose inhaled corticosteroids alone. The add-on treatment uses omalizumab for severe allergic asthma, and for severe eosinophilic asthma, we can use mepolizumab, reslizumab, benralizumab, or dupilumab. If you made it this point in the video, thanks for watching. If you're wondering why I haven't been posting, it's because I've been sick and I had work piling up, but I got better and decided that I'm gonna post a video no matter what this Friday. Anyways, until next time, stay happy and healthy.